So this is a 50-year-old woman with multiple grouped papules on the face. And this is a very nice example, a very characteristic example of two different diseases that often occur in association with one another. The first thing you'll notice here is that the hair follicles are incredibly prominent. They're very large, they are dilated and expanded, and they have open spaces in them that are filled with blue myxoid or mucinous substance. So if you're dermatology trained, learning derm path, you will often use the word mucin, and pathologists tend to use the word myxoid. I use those two terms interchangeably, but this is basically what we would call mucin. It's blue, kind of fine, granular, gooey substance that is filling up and expanding the follicle, and it's actually breaking apart and distorting the individual keratinocytes of the hair follicle while it does this. So the follicles are filled up with this mucin, and because of that, they get expanded and dilated. So they're a lot larger than usual. So this is called follicular mucinosis, and this is probably the best example I've ever seen. And in fact, I remember it very vividly because I first saw this case very soon after I had just submitted the proofs, final proofs for my dermatopathology survival guide book, and I didn't have a really good example of follicular mucinosis in my collection, so I had to kind of settle for one that I didn't love. And then this case came in, like, of course, a few weeks later after it had gone to print. So in any case, this is like the most dramatic example of follicular mucinosis. You can see very nicely the blue mucin. If you need, you can do stains to highlight this mucin. You could use colloidal iron or Alcian blue, but to me, it's so obvious here on H&E that we don't need to do any stain to prove it. One thing I'll point out about follicular mucinosis is that sometimes when you're not cut right into the middle of the follicle, it looks a lot like spongiosis. It looks like white space, and it's hard to see that there's a little bit of a bluish tinge. It's very subtle. So anytime I see expanded follicles with what looks kind of like spongiosis in the middle, I'll consider the possibility of follicular mucinosis. And a lot of times on deeper levels, you'll end up cutting into a follicle and seeing a good follicular mucinosis. So there's a little tip for what I think about when I see kind of a spongy looking follicle like right here. Cut deeper, see if you find some mucin, because you just might have follicular mucinosis on your hands. Okay, follicular mucinosis is kind of complicated historically because there's another term called alopecia mucinosa that has been used kind of interchangeably with follicular mucinosis, and there's been debate in the literature about how these terms should be used. There's also been debate about what these terms mean. The one school of thought is that all of these are basically a variation of Mycosis fungoides, folliculotropic mycosis fungoides. This particular case actually is that. There is folliculotropic mycosis fungoides here, which I'll talk about in a second, and it's also occurring hand in hand with follicular mucinosis. But some people, including myself, believe that there are some cases of follicular mucinosis that are not associated with Mycosis fungoides. They can be seen in a variety of different reactive conditions or incidentally in association with other diseases. And then there are also some that are thought to just be idiopathic, although over time a significant subset of those have been found to be clonal for T-cell clonality studies. So there's debate, and even those patients that have indolent course and good prognosis, still some of them are clonal. So it seems that there are some cases of follicular mucinosis that may represent like a variant of folliculotropic mycosis fungoides, but one that's very indolent and behaves well. I've certainly seen some cases of patients with follicular mucinosis, like in the background skin in a basal cell carcinoma excision, and those patients, to my knowledge, never developed obvious mycosis fungoides. But if I see follicular mucinosis, I think right away, could there be mycosis fungoides here involving the hair follicles particularly? And if I don't find evidence of that, I think it's worth mentioning in the comment in my report that follicular mucinosis is often associated with mycosis fungoides, cutaneous T-cell lymphoma, for those of you who are not familiar with that. And I want the dermatologist to follow the patient and keep an eye on them, or do a full skin exam to make sure they don't have any other clinical features that would suggest mycosis fungoides. So why is this case, why did I get to the diagnosis of folliculotropic MF in this case and not just follicular mucinosis? Well, here's the thing that I noticed right away. In addition to the expanded mucin-filled follicles, look at all of the lymphocytes. hugging each of these expanded follicles. There's very prominent perifollicular lymphocytic infiltrate. Let's look over here on the other piece, which unfortunately is upside down. Let's see if we can rotate this back. We can. Good. You can again see very nice follicular mucinosis in here. And there's expansion of the follicles surrounded by lymphocytes. Now, a lot of the lymphocytes are kind of small, and that's the in-depth lecture on Mycosis Fungoides is outside the scope of this video, but I suppose one day we'll have to have that conversation. I do have another short video on MF, and I'll put a link to that down below so you can go watch that video about conventional MF. Okay, so the thing here that I'm seeing is a lot of lymphocytes around follicles, and it looks to me like they are infiltrating into follicles. Oh, that was what I was going to say, was that Mycosis fungoides, in some cases, will have larger atypical kind of cerebriform looking brain-shaped lymphocytes, but I've seen many cases where the lymphocytes are relatively small and not terribly atypical. And if you're anything like me, unless the lymphocytes are really, really atypical, I have a hard time personally assessing the degree of atypia in lymphocytes unless they're dramatically large and ugly looking. So that's probably why I'm not a hematopathologist, because I find that really challenging to do. So there are a lot of lymphocytes around the follicles, and not only around, but they appear to be infiltrating into the follicles. So to me, finding a lot of lymphocytes infiltrating into follicles is a useful clue for folliculotropic MF. If they have atypia or have a large nuclei, then that's very helpful. Also, if they have an atypical immunophenotype, and clonality studies can be helpful, although like I mentioned earlier, there's some debate about what the meaning of T-cell receptor clonality is in the context of follicular mucinosis, if that's the only feature you have. Okay, just to briefly mention, the clinical features of regular conventional Mycosis fungoides are usually multiple patches and plaques in the trunk, the buttocks, the abdomen, the back, the sun-covered areas oftentimes, and they persist and they expand and spread over time. And then microscopically on a biopsy, you'll see lymphocytes tagging along the basal layer of the epidermis and trickling and spreading upward and making little Poirier microabscesses in the epidermis. So look, we don't have any of that here. There's no lymphocytes getting into the epidermis really at all. This person has a little bit of lichen simplex chronicus from chronic scratching, and they've got some enlarged melanocytes from the chronic sun damage, and you can see their solar elastosis right here, but they don't have any epidermotropism. So what they do have, though, is folliculotropism. And let me show you the immunostains for this case to demonstrate. It's a little bit hard to see here because the follicles are so distorted by the mucin, and there's so much busy it's very busy. There's a lot of cellularity and the follicles look weird, but it's really kind of hard to tell exactly how many lymphocytes are there. So here's when immunostains can become useful. Here's an example of the CD3 immunostain, which for any beginners watching this, CD3 is a marker that stains T cells, regular T cells. And the CD3, you can see, shows T cells, numerous T cells wrapping around each of the follicles and infiltrating into the follicular epithelium. So when you go closer here, look at all these cells in the background that are negative. Those are epithelial cells, follicular epithelial cells, keratinocytes. And the background negative cells, that's what those are. And you can see all of the numerous T cells infiltrating extensively into this epithelium. This is basically like what you see in the epidermis in regular Mycosis fungoides, only here it's localized into the follicular epithelium rather than the epidermal epithelium. So this is the classic pattern you want to see in folliculotropic Mycosis fungoides. I will point out something else. There are some cells floating in here that are negative for CD3. Probably those are Langerhans cells. And I think it can be really hard to tell apart Langerhans collections, which can exist in the epidermis, like in spongiatic dermatitis. And sometimes you see collections of Langerhans cells in hair follicles also. So on H&E, with practice, you can get pretty good at it, but I've definitely had times where I wasn't totally sure if I was looking at lymphocytes or Langerhans cells in the hair follicle. And in those cases, it can be very helpful because CD3 will be negative in Langerhans cells. And I will point out CD4 can be is positive in Langerhans cells and in other monocyte-derived cells like histiocytes, in addition to CD4 positive T helper cells. So anyway, this is CD3, which shows extensive involvement of follicles. And let's look at the other piece over here. Same thing. You can see just really dramatic perifollicular lymphocytes and not just perifollicular, but intrafollicular lymphocytes. The lymphocytes are infiltrating the follicles. And note that up here, when you look at the epidermis, not a bit of epidermotropism to be seen. Almost no, very, very rare lymphocytes, which is within the spectrum of normal to me to have occasional lymphocytes in the epidermis, even in relatively normal skin. Okay, now I want to point out one thing though, that folliculotropic mycosis fungoides sometimes occurs hand in hand with conventional mycosis fungoides. I've seen cases that had classic mycosis fungoides, patches and plaques, and also had folliculotropism. And then I've seen cases like this one where there was purely folliculotropism and no epidermotropism, no involvement of the epidermis at all. So you can have it both ways, all right? While conventional MF has patches and plaques on the trunk usually, on folliculotropic mycosis fungoides, the kind like this where you just have folliculotropic MF, it often presents as grouped, kind of clustered folliculocentric papules. So because of that, when you have folliculotropic MF without the conventional form, it often gets overlooked clinically or thought to be something else, okay? So cases like this one I've seen where the clinical diagnosis was maybe weird rosacea because they had some reddish papules on the face. And let me tell you, I saw the clinical pictures. They were not incredibly impressive. Certainly, I did not look at that and think, oh, that's got to be mycosis fungoides. No way. So I think a lot of times folliculotropic MF, because it's rare, it's a lot more rare than conventional MF, and because it has a very unusual and sometimes subtle presentation, it can get overlooked clinically. And I've definitely seen cases that even microscopically really looked like rosacea, and it was only after multiple biopsies over time that it became obvious that the patient actually had folliculotropic MF. So it can be a very tricky disease to diagnose. It's an important disease to keep on your radar when you see a lot of lymphocytes around hair follicles, and particularly if you see it in association with intrafollicular mucin. Also, some cases of MF can be syringotropic. They can wrap around and infiltrate the eccrine sweat coils and sweat ducts. This case does not have that feature, but I've seen cases of that too. So those are unusual variants of MF to consider. All right, so I'm going on and on about it. I was going to make this a quick video, but those of you who've watched my videos before know that that rarely happens. So this is the CD3. Now let's look and see what the CD4 and CD8 looks like. So here is CD4. Wow, dramatic, right? It's like almost every T cell there is the CD4 positive, okay? And for comparison, let's look real quickly at CD8. Almost no CD8 staining. So incredibly dramatic. Now, not every case of mycosis fungoides is going to be this obvious, okay? The problem is that the T cell immunostains can be helpful in some cases, but in other cases they can be very difficult to interpret. I find them particularly helpful when it's like this, when you've got, 95% of the T cells here are CD4 positive and almost no cells that are CD8 positive, or occasionally vice versa. Mycosis fungoides is usually CD4 positive, CD8 negative, but there is a CD8 positive subset that can occasionally happen. Although, to my recollection, I don't personally recall ever seeing a CD8 positive folliculotropic MF that I can think of. I'm sure it's been described because every weird variation that can possibly happen has been described, but the handful of CD8 positive MF cases I've seen were regular epidermotropic MF. And that's a topic for another video. So what we're seeing here, probably these CD8 positive cells are background non-neoplastic T cells, just background regular T cells that are here mixed in with all the CD4 positive T cells which make up the tumor. These are actually the tumor lymphocytes. And you can see them again infiltrating into the epithelium of the hair follicle here. And I'd like to point out something. Normally what I like to say is that for normal T cells, if you add together the CD4 positive cells and the CD8 positive cells, it should equal up to all the cells that you see in the CD3, because CD3 should stain all normal T cells, should be CD3 positive. And T cells are either CD4 positive, T helper cells, or CD8 positive cytotoxic T cells. So the mixture of CD8 and CD4 positive T cells should, if you add them all together, should equal the number of CD3 positive cells you see. But here, look what we have. This is CD3, and here's CD4. Did I make a mistake? Did I label it wrong? Well, that's always possible, but it looks like there's more CD4 positive cells than there are CD3 positive cells. How is that possible? Well, I mentioned a moment ago, there are other cells that stain with CD4 aside from T helper cells. And those cells particularly are histiocytes and Langerhans cells. And all of those cells I pointed out in the previous slide back on the H&E, Those guys are Langerhans cells. All right, I guess I pointed it out on the CD3. See those cells right there? They were CD3 negative cells. Those are just Langerhans cells that are trapped up in the middle of this follicle. And that can be seen in a wide variety of reactive processes. And in this case, it's happening alongside the Mycosis Fungoides. Let's go back and look at that on the H&E. Oh, maybe that follicle is not. Oh, here it is. It's upside down. Well, the cut that we're cutting, we're not cutting quite in the right place. So that one collection is not quite visualized here. But here you are. These cells right here, these are Langerhans cells. Now, this is important to point out because, look, if those ended up being T cells, they would be way, way bigger than normal T cells, and I would instantly be worried about lymphoma. If I see cells the size of Langerhans cells that stain with CD3, then I'm at Mycosis Fungoides until proven otherwise if they're inside the epithelium, either the epidermis or the hair follicle. So it's really important to make sure you can distinguish Langerhans cells from lymphocytes, because the distinction can be the difference between, this is just a reactive process, or this is T-cell lymphoma. Okay, so really important to remember that. And I feel like a lot of people forget that CD4 is it's a molecule. It's more complicated than I understand or remember, but it's, I believe, a molecule involved in the antigen presenting process. So it's positive not only on T helper cells, but it's positive also on histiocytes and Langerhans cells, because they play a role in antigen presentation in the immune system. So there's CD3. Negative in those Langerhans cells. CD4 stains the Langerhans cells and also stains the vast majority of the lymphocytes, including the ones infiltrating the follicle. And look up here. Here's a nice useful trick. If you're looking at a stain and trying to figure out if it's CD3 or CD4, go look up here in the epidermis. These little branchy looking cells, those are normal Langerhans cells. Remember, Langerhans cells live in the mid-spinous layer of the epidermis. And this is the reason why when I'm looking at a T cell infiltrate and trying to decide if it's Mycosis Fungoides, if I do immunostains, I don't just do CD4 and CD8. I always use CD3 with it, because that way I can make sure that I don't get tricked by Langerhans cells. Because if you do a CD3, all these cells will be gone. And again, in some cases like spongiotic dermatitis or contact dermatitis, you can have a lot of Langerhans cells in the epidermis. And if you just do a CD4, you can go down the tubes and get burned by thinking that those are CD4 positive lymphocytes instead of Langerhans cells. So this is the CD4. Dramatic, look at that. Really immense infiltration of the follicle here. CD8, like I said, is almost completely negative. And in this case, we did a CD7. And CD7 can be lost in some cases of Mycosis Fungoides, but it's not always really clear. It can also be reduced in some reactive processes. So you have to use caution when interpreting these immunostains. But here, for contrast, is the CD7, and you can see that CD7 is completely lost in all of those interfollicular lymphocytes. And basically, it's pretty much only staining the background non-neoplastic CD8 positive cells. See, it's pretty similar in pattern and distribution to this CD8. So probably these background normal CD8 positive T cells are the cells mostly that are staining with CD7, as well as maybe a small minor subset of the lymphoma cells. But really, there's a dramatically decreased expression of CD7 in this case, and that can be helpful. CD5 occasionally can be lost, but I find that most cases of Mycosis Fungoides that I've seen retain CD5. So if it's lost, it's definitely abnormal, but I find that that's only a small minority of cases. So here we didn't do CD5, just CD7. And normally, a normal CD7 should look similar to your CD3, because normal T cells should stain with CD7, although, like I mentioned, reactive processes sometimes show variable amounts of diminished CD7 expression. So going back to the H&E, we have here an example, a very dramatic example of follicular mucinosis. And the reason that sometimes that's called alopecia mucinosa is because occasionally, if it occurs in a hair-bearing site, like the scalp or the eyebrows, it can cause alopecia alongside it. So you can have hair loss, and then these papules that on biopsy show mucin within the follicles. So that's follicular mucinosis. And in this case, it's hand in hand with folliculotropic mycosis fungoides. And oftentimes, folliculotropic MF is more difficult to treat and has a higher risk of progressing and having a worse prognosis than conventional forms of MF. So it's really important to know about because it's rare, it's clinically kind of confusing and tricky and doesn't look like classic MF. It microscopically can be really challenging, and it actually has a prognostic and treatment differences from regular conventional Mycosis fungoides. So it's an important thing to always keep in mind and make sure that you don't overlook. I hope you enjoyed this case, and if you'd like to see if you haven't seen them yet, I have links to the digital slides that I'm using here on kikoxp.com, and I'll put those links down in the video description below if you're watching this on YouTube, or if you're watching this on Kiko, I'll put them down in the comments section. So thanks for watching, and have a great day.